Good afternoon, everybody, and welcome to today's webinar, From Volume to Outcomes, Measuring Success in a Value-Based Environment. My name is Monique Dever, and I am the moderator for today's presentation. More importantly, Scott LaVigne, who is the Local Health Director for the Franklin County Health Department, is our presenter for today. Scott has served for 9 years as the County Director of Community Services in upstate New York prior to coming to Franklin County in North Carolina. In that role, Mr. LaVigne was CEO of the county-operated outpatient mental health and substance abuse clinic, and each year developed a data-informed county plan in the areas of mental health, substance abuse, and developmental disability services. Mr. LaVigne also held leadership positions in the New York State Conference of Local Mental Hygiene Directors and served as chair of that organization prior to accepting his current job here as the health director for Franklin County. He has over 29 years of behavioral health experience, including administrative and clinical management of outpatient substance abuse and mental health clinics, a successful private practice, and has, prior to relocating to North Carolina, worked extensively in the New York State for state and local officials to develop and implement oversight mechanisms for Medicaid-managed behavioral health care in New York State. Mr. LaVigne holds a Bachelor of Arts degree in psychology from Hope College, a Master of Social Work degree from Boston College, and a Master of Business Administration degree from St. John Fisher College. He has been the health director in Franklin County, North Carolina since November 2016. Before we get started, I just want to give you a little bit of housekeeping. We have questions will be answered somewhat throughout the presentation, but mostly we'll make sure they get covered at the end of the presentation. If you have questions, please go ahead and put those in the questions box in the pop-up window on your screen. You will be in mute mode throughout the presentation so that we don't get any feedback. So just go ahead and put your questions in, and Scott will get to those periodically, and we'll cover them all at the end. So at this point, we are going to shift presentations over to Scott's presentation, and let's get that one started. Let's take this off first. Pardon the, let's get to okay. All right, and Scott, take it away.
All right, thank you very much. Thanks for having me. Let's see, okay. So, oh, I see, very good. All right, well, true confession, my name is Scott and I am a recovering data nerd. And I want to know, I can't tell how many people said hi, Scott, but I know there's probably some that did. Full disclosure, I love big data, and I cannot lie. I believe in embracing the inner data nerd within, and I actually did a conference on pivot tables, and one of my peers got up and said, pivot tables changed my life, and I couldn't stop myself. I said, amen. So there's no question that I love data, and there's a lot of good data that's out there. We don't suffer from a lack of data. What we do suffer from is a lack of ability to translate that data into actionable information. And so part of what we're going to be talking about today when we talk about value-based is a discussion that naturally spills into data as well. Okay. North Carolina and most of the rest of the country is in the process of transitioning from a service or service-based system to an outcome-based system. And some states are a little bit further along in that process than others, but ultimately it's a direction we're all moving in. Here in North Carolina, the 1115 Medicaid waiver, and I love all these numbers, 1115I, 20, they sound like BMWs. But the bottom line is an 1115 managed care waiver was submitted to CMS in 2016 for North Carolina. And there's been numerous revisions, and there'll be numerous more revisions. But one thing is definitely clear about what's going to happen. At some point, CMS is going to be paying MCOs, provider-led organizations, and a veritable alphabet soup of other managed care entities a per member, per month fee to deliver quality patient outcomes. And that is going to happen. So how does your agency handle the inevitable transition that this is going to entail? Well, there are some forward-thinking management teams that are constantly scanning the horizon, looking for what's next and trying to anticipate and leading their organizations steadfastly into the land of early adopters. They're in the minority, but they are out there. There are many who send their employees to boring PowerPoint presentations about, wait a minute, I'm going to just move on from that one. And then there's also people that read up on change management. Now, I love this slide because it's Change Management for Dummies, and I'm a big fan of the For Dummies books. It's how I learned Excel. It's fantastic. And I like it because change is a very beautiful thing, but change is also scary, and that's why I thought it was great that this book was the German version of it, because nothing is more scary than hearing about change in German, mach dich schlau. It sounds terrible. So anyway, or you could have management that basically says, yeah, you know what, it's not going to happen. I don't want to think about this. Please get back to me later, in the hopes that it'll somehow go away. And then my personal favorite, smug management, who sits back and waits and says, yeah, it's never going to happen. I'm just going to sit here doing what I've been doing and nothing's going to change because it hasn't. And we've been talking about this for years and nothing's happened. Well, you know, I'm here to say that actually it is going to happen, and it started happening in other areas. And we'll talk more about that a little bit. So let's look at what value-based practices, some precursors to value-based practices that have already been out there. Most people are familiar with the Triple Aim initiative, and that's about improving outcomes, the satisfaction of patients, and the overall per capita costs of healthcare. And that aim, that Triple Aim, that's been around for quite a while. Some other movements that are looking to emphasize outcomes focus on integrating behavioral health into primary health care, or the other way around, depending on which provider you happen to be. New attention being paid to the social determinants of health. That's clearly focusing on outcomes and recognizing that there's a lot more that goes on outside the four walls of the examination room. Behavioral components of chronic conditions and motivational interviewing. Cardiologists recognizing that, in fact, you know, a lot of, while they can repair hearts, they can't change behavior, and recognizing that there's merit in delivering some of that service to a better outcome. Trauma-informed care, recognizing that many of our patients come into the system with significant adverse childhood experiences, and improving the outcome and the processes that we operate under. Some provider report cards have started to emerge, and the New York State Office of Alcohol and Substance Abuse Services on their website gives you a link where you can go and check out any licensed treatment provider of substance abuse services in the state and find out how they rank on certain metrics, and you know, they're given a report card grade. And finally, value-based care, which is frequently labeled as value-based purchasing, which sounds like a purchasing component, and I'm not quite sure why purchasing is sticking, but that's the phrase that we're using, so that's kind of what we're stuck with. It's kind of like Kleenex. I'm not sure who coined the phrase, but we refer to it now as any facial tissue is called Kleenex. So value-based care is quite simply a way of letting other people know just how effective your programs and services are at really changing and improving people's lives. But what is value? How do you define it? What does it look at? Well, is it good outcomes? Satisfaction? Is it access to the best providers and at the right time? We can meet demand by getting that provider to where they're needed at the right time. And is value a fair cost to everybody? Most people are probably chuckling at this point that I put payers in the mix, because most payers probably don't think that there's a fair price, but there is a fair price. And then finally, if I am providing good value, how in the world do I know it? And how can I let the people I serve, my payers, and the community know? Okay. Just going to advance real quick here. So how do we define value? How is it operationalized? Well, the best definition I've heard comes from a conference I went to in Washington, D.C. several years ago, and it came from a person named Josh Rubin, who was formerly with the New York City Department of Health. Josh has, I think, since moved on to work in consulting. Still lives in New York City, but is doing some consulting work. And it was very helpful for me to conceptualize how I could actually, first of all, get my head around value, and then second of all, what I could do to start to begin to see what value looked like. And so it is in the form of a mathematical equation, but there's really no math involved in this. It is simply a formula that's used to illustrate I'm clicking on it here, the different components of value. In its simplest form, value is defined as satisfaction plus outcomes multiplied by volume and divided by cost. It really is that simple. Now, there's a lot of components here, but these are things that we're already vaguely aware of with the exception of outcomes. So we're going to save outcome till last when we break this whole fraction down.
We are not showing our screen.
Oh.
Pause for a second.
Okay, we're going to pause for a second because apparently we're not showing up on the screen.
I can't find my mouse over here. How do you do that?
So we're going to take.
Sorry about that, guys.
It's showing up now? Mm-hmm. Very good. All right, so there's the equation. It's satisfaction plus outcomes multiplied by volume divided by cost, and that is how we arrive at what overall value is. So let's take a look at some of the component parts. All right, try it again. There we go. So satisfaction. Most of us are doing some kind of surveys with our clients or our patients, even our staff. Sometimes the community as a whole, if you're looking at public health. But satisfaction surveys and satisfaction by itself is not the whole equation, as we just saw. It's a part of that equation, satisfaction plus outcomes. High patient satisfaction can still mean that you're delivering poor value. And the example I'll give, unfortunately, comes from the home health agency that I run. When I first got to Franklin County, we run a home health agency, and I was shocked at the high customer satisfaction that we had. When I examined our outcomes, there was a slightly different picture. And it was more than a slightly different picture. It was a substantially different picture. And what I found was that on some levels, our patients were very satisfied because we weren't challenging them to change behaviors. And so they really liked us, but we weren't really helping them. And so you can have great satisfaction, but it has to be across all levels, not just the patients, but also your providers. If you're implementing something and your providers aren't happy with it, it's not going to happen. Same thing with support and the payers. If you only have one or two people or groups satisfied, you're not going to be delivering overall value. And the last thing is what I used to tell parents when I had a private practice. Parents would come in and they were beating themselves up about being bad parents, acquainting parents with the phrase good enough parenting. Sometimes parents are rock stars, and then in other moments they can be not so rock star-like. Well, good enough parenting, sometimes you just have to strive for good enough satisfaction. So let's take a look at volume. And this is something I think most of us are far more acquainted with than anything else. As a service delivery industry, we know how to measure volume. We look at units of service, number of procedures, unique patients seen. We've got all different ways to slice and dice that. And clearly, volume is in the mix. You have to have sufficient or good enough volume if you're going to be delivering overall value. Now, you could have one patient an hour, and that patient could spend 30 or 40 minutes with a doctor, and they would walk out with probably exceptionally good outcomes and very high satisfaction, or not, depending on the bedside manner of your doctor. But you would be losing out on volume, and your cost structure would be unsustainable, and so you would not be delivering overall value. So this is a nice way of looking at the balance that you need. Cost. People frequently ask me, and I'm not sure how many other public health directors are on, but what's your real cost? And, that depends on who's asking and what they're looking for. But when you break it down, there is a real cost for every service that you deliver. And it's really not that hard to figure out. You'd have to sit down with your business officer, but you can break it out, and it is easy to figure out. It's important to know that when you're working in a value-based environment, because cost is the denominator. It's the one that gets divided in. It's one of the factors that's all by itself on the bottom. It is something that is very important, but it's not the only component of value. And some people think that, all I got to do is cut my costs. And, if it were all, you would not be in an agency or a program that can develop the economies of scale sufficient to have low cost structures. It's all right. Everybody can't be Walmart, and all you have to do is ask Target about that, and any other store that's tried to be that way. You can't compete. Everybody can't compete on cost. So because it's only one component of overall value, if you can deliver high satisfaction, decent volume, and some great outcomes, you can compete with anybody, even with high cost. And that brings us to why everybody's probably here, which is looking at measuring outcomes. Basically, do your patients get better? And if so, how do they do it? And how do you document it? Well, we definitely need quality data that can operationalize what good outcomes are across all of the different medical or behavioral health conditions that we actually see people around. In the current service-based system, most of what we're collecting is process metrics, access to care, how's our overall utilization, how long are people having to wait, how long between the phone call and the first appointment. There's all kinds of metrics related to that. And capacity, how many people can the doctor see in an hour? And so we're really familiar with that kind of data. But that is not outcome measurement data. One of the best examples of what strives to look at outcome measurement is the HEDIS measurement. And that comes out of NCQA. Basically, it stands for Healthcare Effectiveness Data and Information Set. A lot of you are probably familiar with it. 90% of all HMOs or healthcare organizations gather this information from providers and report out to their governing body, NCQA, and also to their payers, namely corporations, companies, and the government that pays for managed Medicaid expenditures. Looks at 94 measures across 7 different domains of care, and it collects a mountain of data. But the good part about it is that because pretty much most plans are collecting it, it really gives you an opportunity to compare plan to plan on an apples-to-apples basis. It's also how MCOs are rated by their industry. And so if you can make your MCO happy by delivering really good HEDIS measurements, process metrics, you're going to make them look good. So let's look at the HEDIS process metrics. And apologies to those with literary minds among you. Process metrics everywhere, which is hard to say, but nary an outcome data point to ponder. If you look at HEDIS, every year they update what they're looking at. Go online, look at the 2018 table of changes under the section for effectiveness. And what you will see is it is primarily process metrics, guidelines, basically childhood immunization status, looking at screenings, breast cancer screenings, cervical cancer screenings. Are you delivering the appropriate number of tests? But there's not one outcome. I think there might actually be one, and maybe this is like Where's Waldo? If you go online and see if you can find it and email it to me. So HEDIS scores are important, though, in a value-based environment, because if your MCO is satisfied, well, that's good, because that's part of the payer mix. That's part of the overall client base that you have, the MCO. And so HEDIS scores can actually be a part of satisfaction. But as I said before, most HEDIS metrics are not assessing outcome. You know, and you can lead a patient to the exact right test, make the right referral, make sure that everything is documented in pristine fashion that would stand up to a JCO or an NCQA or a HEDIS, anybody wanting to look at that. But at the end of the day, you still might not get a good outcome because they're just process metrics. So basically then, how do we document good outcomes? Now, there are some areas of healthcare that are way out ahead of the curve when it comes to using outcomes in an effective way, and home health agencies are the one that I think is going to ultimately turn out to be a model that we are all going to end up living with on some levels. So I think it's worth exploring further because it's one that CMS develops for home health agencies by requiring them to use an assessment tool. And let's see if anybody can spot the problem with their acronym. It's called OASIS, which stands for the Outcome and Assessment Information Set. But I defy anybody to show me where that other S comes from in this acronym. And yet everything says OASIS. I think it's because I have no idea why they did that. But it is a very helpful tool because what CMS does is it says if you're going to be a home health care agency and you're going to provide service, you're going to use this outcome assessment. And you're going to use it to determine if home health is even necessary from the outset. You're going to also use it to determine what types of care you can use in treatment planning. And finally, you're going to use it as a pre and post test administration to document outcomes for your patients. This is an important model to understand because I think it's ultimately the model that's probably going to emerge that we're going to have to live with. And there's a link there if you want to go and explore the OASIS without the other S at your late leisure. They started this in 1999, which seems like a lifetime ago, given where it's at right now. And they started just requiring the Medicare certified home health agencies to collect this information. And eventually it turned into, and this is the important part, it turned this information into multiple different ways of reporting it out, depending on stakeholder group. And one of the first was they started calculating quality reports and specifically looking at quality and performance improvement efforts. So as I click next, performance data started showing up on the website. And if you go to Medicare.gov and look at the Home Health Compare section, you're going to get outcome measures on how well your home health agency did in meeting their outcome expectations. And that started quite a few years ago. In 2015, they made it a lot simpler for everyday folks looking at that by creating a star rating system so that anybody could go online, look at it, and figure out just how well their home health agency was doing. So you might be asking yourself, okay, I don't run a home health agency, so who the heck cares about this? Well, we should, because the next thing that they did with all of this information is they went on to tie individual home health agency reimbursement rates based on these OASIS scores. So let's look at outcomes and reimbursement. You know, is it a shotgun wedding or is it a marriage made in heaven? You know, jury might still be out on that, but I think it's got the opportunity to be absolute bliss. In home health agencies, basically how CMS sets rates for individual agency is they look at your overall performance using that OASIS tool for all the patients that occurred in the previous year, and they compare that to your agency's previous years so that you're getting a true measurement of how successful you've become, how much improvement you have made as an agency in delivering performance-based outcome for your clients. The second area that they do is they compare that to all of your peer agencies of similar size and scope. So you get a two-level comparison, and they use that to calculate your rate. Now, does that sound familiar to us? Here we have the blending of patient satisfaction, which is the next thing they look at, and with their rate setting calculations. And they put the two together, which is exactly what this equation says would probably be happening. So they have patient satisfaction and outcomes being directly tied to reimbursement. So for us here in the Medicaid, primary care, or specialty care world, if CMS is using that for home health, and they've got a model for pairing satisfaction and outcome data to reimbursements, it's pretty reasonable to assume they're probably going to have a similar model that they're going to be throwing our way at some point very soon. And really, what they're looking for and what we have to struggle with is to start collecting data on outcomes and volume and process metrics. But we really need a functional outcome measure, and we need a tool similar to OASIS for the primary care group. So that gets to the lion's share of what we're going to talk about today, which is measuring outcomes. Now, the first thing you're going to need to do is find a measurement tool, and that is no easy feat. If you're looking for something that you can use no matter what the condition, be it diabetes or schizophrenia, you're going to have a hard time. Now, I'm not here to endorse any one tool over another, but what I'm going to do is talk about the tool that I selected, which is called the Daily Living Activities 20, or the DLA 20 from MTM Services. The reason I selected that is because I'm in the process of integrating behavioral health into my primary care clinics, and this tool came from the behavioral health field, it has a strong evidence base for looking at functional needs across 20 different domains, ranging from employment to housing. So it includes the social determinants of health, it includes overall functioning in areas that we don't collect or frequently look at when we're meeting directly with patients, but that we hope would improve as their physical health and behavioral health improves. I went out and got grant money to allow me to do this. It wasn't cheap, and so there is grant money out there that allows you to do it, but the reason I got that grant money is because it was a means to an end. It allowed me to have a tool that I could measure impact. And I'll get to that in a little bit for that grant funder, which was Triangle North Healthcare Foundation here in North Carolina. So the grant that I got funded a Train the Trainers module that allowed me to train our staff. It was a one-time only purchase. So once I got it and once my staff are trained, I'm done. It's now mine and I can use it, and all the updates will come to me if there's any, but there's no ongoing charges, which is one of the other reasons why I liked it. And we're now in the process of training our staff and concurrently doing train the trainer staffing. And we've paired it with a motivational interviewing training initiative also funded by the grant. So why measure outcomes today if it's not required? Well, those in business are very aware of the Hawthorne effect, which is something that happens in time studies that they first noticed when you're looking at a problem or a particular situation. People will tend to do things differently and to act differently just because they know you're looking at them. So the simple act of letting people know that you're paying attention to outcomes is going to improve outcomes just by virtue of that fact alone. Not enough for you to be able to ride coattails. You're going to have some meat behind this. It can't be just a paper tiger, but you will get some for that. The other thing is that it really establishes a nice background set of data to show that you've been supplying and providing quality outcomes for your patients before it was required. And you've got a database that will substantiate that. It also allows you to be, if you're looking at human resources, it allows you to do strategic, targeted QA, QI activities right down to the provider-specific area. If you're gathering outcome data, you can go to your EMR, bring up diagnoses by provider, by outcome, and you can see which provider is doing well with what kind of diagnoses and as a way of counseling them to improve or as a way of rewarding really good top-notch service. It also allows you to identify strengths and weaknesses before value-based planning comes to fruition. And the last thing is that even in a low volume provider can be an integral part of your overall clinic success. And the example I always use is I was running a mental health clinic. And for those behavioral health providers that are on, you'll know what I'm talking about. There are certain people with certain diagnoses that are a little bit more to manage within the clinic structure than others, and one in particular is borderline personality disorder. I had a therapist that was able to knock the ball out of the park in terms of the ability to engage people with that disorder, to keep them coming in for treatment, albeit with very high no-show rates, but to keep them engaged and to keep them out of the hospital. But by stacking her with these clients, her productivity did not meet the required standard for the clinic. I was able to go back and show exactly why it was important not to hold her feet to the fire, because by her taking and working with these clients, those clients were not now being seen by other therapists whose productivity was free to not only meet, but actually went on to exceed their productivity expectations. And so because one person took a hit, everybody else exceeded. That takes a different view of productivity that I think is going to be an important model when we look in a value-based environment. Some of the parts is what we're looking for, and one person might allow the rest of your organization to flourish when they themselves might not be flourishing in a value-based system. So what are the next steps in your value-based journey? Essentially, there's the equation again, and the first step is taking a look at what you're doing right now in this service-based environment and looking at each individual component, as it exists today, and then ultimately coming out with what is your current value niche? You know, where are you currently excelling in this equation? Is it in outcomes? Do you even know? If you don't know, then that's not where a starting place for you. It could be that you're delivering good value outcome, and you may have some anecdotal information. And so what you might be leading you to do is to come up and to secure some tools to be able to document that. Is it high satisfaction? And why is that? Is it the number of people? Do you have a well-oiled machine clinic or behavioral health program that can get people running through at fast clip pace? Or is it your cost? Are you working for a large system that can absorb a large cost due to economies of scale, and can deliver low cost due to economies of scale? And so identifying your current niche is important because it'll give you a springboard to your future value niche and future value improvement opportunities. Now, we can't all be high volume clinics, and quite honestly, we shouldn't all strive to be high volume clinics. We should have good enough volume. In terms of satisfaction, we should make sure that all of our stakeholders are satisfied enough. Anytime you have one stakeholder who's satisfied more than another and exceedingly more than another, the chances are really good that somebody else is suffering in that mix. Can you document good outcomes for all stakeholders? It doesn't make sense if you've got great HEDIS measures if your patients aren't getting better. Patients document their progress based on how well they get. Are your providers happy in this environment? And if not, why not? And how can you improve that? And the last piece is really to understand and know your real costs and to deliver great value for that cost, to operate within that cost. Now, it's tempting, and I'm going to jump to the bottom, to want to increase revenue. And I'm arguing that for this formula to work and for you to succeed in a value-based environment, really focusing on increasing overall value of your service or program is paramount. And the example I give is a car shop, where if you took your car in and 75% of the time that car wasn't fixed right and you had to bring it back, and when you called to make an appointment, you got one for 3 weeks from now, and when you went and looked on Yelp, lo and behold, they had negative stars, and their costs were way above their competitors, would you realistically go there? And you wouldn't. And so you can rest assured that given the experience of home health, this is the kind of thing that patients are going to start to get access information to, and they're going to be making decisions on that. So if you, and now I'm going to jump down to the bottom, if you're already delivering good value will generate good revenue. It will flow to those with the greatest value in this new environment. And even in this service-based environment, great value can lead to outstanding marketing in terms of word of mouth and traffic coming through your clinic. So it can work now and it can work later. So now I'm going to give you a couple of real world examples. The first, and both of these come from the Franklin County Health Department. The first relates to clinics that we run within the health department. We run a primary care clinic for adults and children, and then we also have a maternal health and family planning clinics. And we're in the process of starting to deliver mental health screenings and then some treatment as well, as we're integrating behavioral health into the overall programs that we have. Now, when you do that, there are some services that you can bill for with a behavioral health therapist in that clinic, and there are a great deal that you can't bill for. And what I'm hoping is that, and what will happen in a value-based environment, is that those that can't are going to show up in an improved outcome. And let me give you an example. Most of the disorders that we see in our clinics today are behaviorally based. If you look at obesity, diabetes, and heart disease being large drivers of primary care clinic traffic or volume, there are strong behavioral components to those particular disorders. If we have mental health providers in our clinics, we have people who are trained to help people change their behavior right across the hall. Now, sitting down and working with someone who doesn't have a mental illness, a diagnosable mental illness, looking at DSM-5, but is clearly struggling with the behavioral changes that they need to make in order to get their diabetes under control, could greatly benefit from a session with somebody who has experience in helping people change their lives, especially someone that's trained in motivational interviewing. Now, can that traditional master's level clinician get reimbursed for that service? Probably not. However, that clinic will, in a value-based environment, ultimately get paid for that service, because once that therapist is done and the client does make changes, that clinic's outcomes are going to improve exponentially, and their funders will notice it and will reward them for that in a value-based environment. So sometimes you're going to give away a service because you're going to recoup it in tenfold down the end of the line. The second one is, and we've been primarily focused on clinical examples, so I'm going to focus a little bit more on those that might not have clinics and grants. Most of us today are applying for grants, and if you look now at the weighting and the scoring for most of these grants, and I've watched it over the last 10 years, the weighting that funders are putting on measuring impact has grown exponentially. And not just saying we think or providing a couple of anecdotal pieces of information, a nice story of success, but measurable examples of how your program or service that they funded has improved the community. So in Franklin County, I applied for and I got a grant from the Triangle North Healthcare Foundation, and that grant was designed to help me bring motivational interviewing training to all of our clinical staff, and then also to provide for integrating behavioral health care to teach them about different mental health and substance abuse screens, and then finally to change our practices, first to do a review and to change our practices for trauma-informed care and more effectively work with folks. Now, how do I know that any of that is working? Well, what I used was the DLA 20, that for everybody that came in that we did motivational interviewing with, we were able to measure now where they were before and where they are now. And so that was just one example of how value-based care and value-based planning can actually help you today in a different non-clinical environment. So at this point, that's pretty much what I have, and I will open it up to any questions. And yes, because I am a geek, and last Friday was May the 4th, be with you, I know. Nothing to me is cooler than squirrels fighting with lightsabers, so I always find a way to slide that into most presentations that I do because I just think it's cool. So does anybody have any questions? And I think there are some that are on.
Yes, I think some of those were from earlier, but
okay.
Thank you very much, Scott. So anybody has questions, go ahead and put those in your questions box. We'll hang out for a few minutes. Guys, if you guys have questions for Scott too, then we can talk about that. When do you think it's going to be too late for those people who are sitting back thinking it's never going to happen?
That depends on the state that you're in. Quite honestly, we've got people from a number of different states. I think if you want to get the benefit of this, getting it done when you're not under the gun is always better. So I would urge people to begin doing this today, even if your state is just looking at it. In North Carolina, we're just looking at it. I'm actually doing this now because I know it's coming, and I want to bring us up into compliance so that when I go to negotiate a contract with a managed care company, I can say, oh yeah, you know what, you can look at our HEDIS measures, but here, I've got this outcome measurement tool, and look at what we're doing. And that's going to carry some weight so that I can go in and negotiate a slightly different contract with that managed care entity than maybe somebody who doesn't have that level of attention to outcome as I do. So I think it's definitely on the horizon. There will be some hiccups. It won't happen as quick as I think it might. Nothing in government does. We like to study everything. There are lots of blue ribbon panels and commissions, but I ultimately think it's definitely coming.
Yes, Scott, I have a question. In the medical side, in the hospital side, there's a lot of movement in this value-based payment systems, a lot of models. They're a little bit more mature, probably been doing it for 3-4 years. If I go to mental health, behavioral health conference, I see the talk, but still the measures are not clear, outcomes are not clear, and stuff like that. We are in public health, a lot of health departments on the call as well. How do you see what's happening in public health, what might happen?
Well, I know that various programs that are mandated for public health agencies to provide really don't contain a high impact evaluation component within them. And so I think it's important, even if you're just looking at an STD clinic or an STI clinic, to know that you've got a tool that can measure value by looking at overall outcome at any program that you use, and that you use it within all of your programs will actually provide an apples to apples comparison for others. Now, in behavioral health, which is kind of where I came from to start with, we were being forced kind of to move in this direction. I came from New York, and we had implemented managed care. And there were metrics that the state was holding the managed care companies to when it came to managed Medicaid in terms of what they had to deliver. There had to be a service within a 30-mile radius. There were, you had to offer an appointment within a certain window of time. There had to be sufficient time or a small enough time frame between the person's first appointment and when they saw the psychiatrist. There were metrics along those lines. We gather those data points. In behavioral health, we kind of know where we're weak in those data points. And the one I just mentioned last is probably the main one. Most programs will tell you exactly how they can get you in tomorrow for an evaluation with a master's level clinician. But when can you see the doctor? That's where most programs fall down. So in a value-based system, recognizing and using these tools, I think are exceedingly helpful, even in the service-based system, because it identifies areas of weakness that you have today, and it gets you out ahead of the curve. Ultimately, all of this data is going to roll up. The state in New York was reviewing how the HMOs were behaving in terms of the overall savings they were generating. They capped what they wanted them to save. They said, take the rest and put it back into outpatient services. We want this to be incentivized. So I think ultimately, if we're going to see a real change, the time to do it is now. It is coming, and the hospitals pave the way. Home health, I think, is probably the best model for us. And we're going to be held accountable to it at some point. And quite honestly, it's probably where we needed to be all along anyway. No other industry operates this way except for healthcare. In no other industry would your outcome be overlooked or not measured strongly. So I think it's been a long time coming.
So in terms of change management, if you do value-based payment, then the thought process to go with it to claim, right? How does it play out with your own team? Because it's a mindset change, right? So does it see any pros and cons of trying to implement that in your health department?
I think the number one problem I had when I was starting to do this was, believe it or not, having to sit down with my biller and have a heart-to-heart conversation about why billing or not having somebody see someone that was a non-billable service and trying to explain that was a good thing to my biller she had a really hard time with that. Now, aside from that, a lot of my reporting mechanisms to my board of health, for example, or if you're running a nonprofit to your board of your agency board, they look at things like how many patients have you seen, what's the size of the caseloads, how many units of service did you deliver, what's your revenue looking like, if you're in a cash accounting system, and that was the first time I'd ever been when I went to work for government. I'd been accrual up until then, went to cash, and I had no way of realistically reporting what revenue was hanging out there because we didn't recognize revenue until it came in. But all of our metrics are designed in a service-based system. So really, we're going to have to start changing some of the language. Revenue is still going to be important. Okay, we're going to need to pay attention to that, but only as it relates to what generates it, which is outcomes. It's not going to be looking at units of service. So I think what will begin to happen is people will start to be reporting how many people have you seen, volume, because that's still important, and what were the outcomes? What kind of outcomes have you been getting, and how does that compare to last year? And what are you tracking for this year to be successful? And the nice part about doing pre and post, because my initial fears when I heard this, is that agencies would cherry pick, that they would select the healthiest people to come in as clients, and they would refer other people out who were least healthy. The nice part about doing pre and post is that we're measuring improvement based on the person, not based on some arbitrary standard that says, how many people have reached this particular standard. So it's interpersonal in terms of intrapersonal, in terms of the ability for measuring that person's progress against themselves. And then it measures against your overall agency, intra-agency itself too.
So Scott, you guys chose the DLA 20 as your measurement tool.
Mm-hmm.
Probably you have familiarity with it from your background.
Mm-hmm.
What other tools are there out there, and are there resources that they can find these other tools?
That is a good question, and quite honestly, I knew about the DLA 20 from my previous experience, and so I Googled a couple and stopped right there because this one gave me what I wanted, and it was something that I knew since I was going to provide more work as well. I would say, definitely start, but talk to each other, talk to the agencies that are seemingly early adopters of most change initiatives. If you look at those that were, adopting an electronic medical record before they were asked to or demanded to or started losing funds from because they didn't have, those would be good people to talk to. As I said, I like the DLA 20 because it incorporated work that I knew I was going to want to do more of, which is behavioral health type work. So I knew it incorporated that. I think if you talk to each other, that's probably the best bet.
Well, I don't see any other questions coming in. Ashok, do you have any further questions? No? Okay. Well, Scott, thanks very much for your time today, everybody. Thank you for joining our webinar today. We will be recording this and uploading this for your future pleasure of watching it. And we'll get further word out for future webinars as well. So thank you for attending today. Scott, again, thank you. And we'll say goodbye.
Thank you.